Objective assessment. In objective assessment, we ask certain question to the patient and we utilize some medical procedure and testing and observe the related things which may help in the diagnosis of the patient. It is more specific and more precise. Now, in objective assessment, number one is observation. What is observation? Observation is a method when any patient enter the room of clinician. From the time when the patient enter into the room, the clinician observe something and observe whether his gait is perfect, his pattern of walking is right, or there is limp in walking or movement, and how the posture he assumes. In observation, generally, when we observe patient from anterior view, we see or we inspect any lateral tilt of the pelvis or sideways swinging of the pelvis, notice any abduction or circumduction of the swing leg, any atrophy of the musculature. In lateral view, we observe if there is any rotation of the shoulder and thorax, spinal posture, hyperextension of the knee, pelvic rotation, etc. Now, inspection is just like observation, but in inspection we must have to expose the part to which we have to examine, and the affected part is compared with the normal side. In this inspection, what we do? We inspect the posture of the patient, deformity, about any deformity he is having, the skin scar, if any skin scar is present or not, and the color of his skin, whether it is normal or pale, reddish, bluish, etc. Now palpation. In palpation, we palpate or the clinician palpate the skin of the patient, the soft tissue, wasting of the muscle, bony protrusion if present, edema, location of tenderness, crepitations. Skin coloration. In skin coloration, the skin may be red or paler or bluish or normal, depending upon the whether it is inflamed or not. The warmth should also be, skin warmth should also be taken into consideration, whether it is normal or the temperature of the local area is raised. Next one is swelling. We observe the soft tissue swelling by comparing to the sound side. The clinician palpate the affected area and feel whether it is swollen or not, or sometimes there may be joint effusion, means around the joint there is swelling. Then the muscle spasm. We test about the muscle spasm, whether muscle spasm is present or not. But how we can see the muscle spasm? For seeing muscle spasm, we just pick the area or the site which is involved, and then we compress the area and notice the facial expression of the patient. If a change in facial expression present, then the muscle spasm will present. Generally, in acute condition, sprain and other inflammatory conditions, the muscle spasm may be present. Edema. Edema is a type of swelling. Or we can edema when the joint is or when the area is swollen, then we can say that edema is present. It may be pitting or non pitting. What is pitting? When we press the area, swollen area, and it does and there we see a pitting, then it is pitting. And when the after pressing no sign of pitting remains, in that condition we say that the edema is non-pitting. Next, nodule. In some diseases such as in rheumatoid arthritis cases, nodule are present in the fingers and around the joint. Therefore, we see whether there is nodule formation or not. Next, tenderness. Tenderness is objective assessment of pain. When there is a painful area, the clinician applies his thumb and press the area and and notice the change of facial expression of the patient. If due to pain the patient pulls his hand or extremities, then or changes is seen during pressing the area, then tenderness will be present. We have to mention the location of tenderness and next one, muscle wasting. We see the muscle wasting exposing the area, and we compare the area from the normal. When we compare whether the muscle is wasted or not, the girth of the muscle is decreased in such condition. Next, the vital sign. There are some vital signs which is necessary to know. They are the heart rate, the blood pressure, the temperature of the body, respiratory rate. Usually, the normal heart rate is 72 to 75 times per minute. The blood pressure is 120 to 80 mmHg. The temperature is around 97 degree Fahrenheit, and the respiratory rate is 14 to 17 times per minute. So these vital signs are very important. Next, we take the weight of the patient. How much weight of the patient is, and we can observe whether the patient is obese or not. Sometimes the patient is obese or overweight. In that condition, it put extra pressure on the joints. Now, sensory examination. In sensory examination, we examine the patient whether the sensation is intact or diminished or absent. So this can be done by touching with a light object or cotton ball, and keeping the eye of the patient closed, and then we ask about the touch. Next, tactile discrimination. In tactile discrimination, it is a 2-point discrimination test which can be done by 2 needles which is placed and eyes kept closed, and then we start the needle or the pin closer and ask about this to the patient. Next one is tightening, contracture and deformity. TCD means tightening, contracture and deformity. Tightening generally due to muscle. When there is problem in muscle, means when the muscle is contracted, then muscle tightening result. Contracture is due to the muscle tightening as well as soft tissue tightening, and deformity is bony fusion, means there is no movement possible. Tightening is tested by applying the force. When the patient perform the movement and up to partial ROM, and when the pressure is applied or passive force is applied by the therapist, then the movement reaches up to full ROM. That is tightening. Contracture is that when the patient perform the movement himself, partial movement is possible, and when the passive force is applied, then some more movement increases but never reach to the full range of motion. Last one is deformity. In deformity, no movement is possible, and even after applying force, passive force, then the movement does not increases. This suggests that there is bony involvement. Next is ROM examination. ROM examination means range of motion examination. Range of motion examination is tested in the joint whether the movement in the joint is full or partial. There are two types of ROM we can measure with the help of goniometer. First one is active ROM and the second one is passive ROM. In active ROM, the patient performs the movement by his own effort, by the patient himself, and sometimes when the patient cannot perform the movement to full range, then some passive force is added and then the movement increases. So active and passive both are important. Next is MMT, that is manual muscle testing. MMT gives information about the power in the muscle, and there are 6 grading: 0, 1, 2, 3, 4 and 5. These are the grading of manual muscle testing. 0 means when there is no contraction, there is no movement. 1 is that when the movement is achieved up to partial range of motion, eliminating the gravity. Next one is 2. Muscle power 2 is that when the patient perform the movement up to full ROM, eliminating gravity but without any external force. Next 3. Muscle power 3 is when the movement is performed by the patient up to full ROM and up to full ROM without any resistance. Next one is 4. Muscle power 4, when movement is possible up to full ROM and against gravity and against minimal force. Next is muscle power 5. Now muscle power 5 is the normal power, or we can say muscle power 5 means when the movement is possible up to full ROM against gravity and up against maximal force. Next one is DTR, means deep tendon reflexes. In DTR, we examine the patient reflexes by tapping the tendon with the help of clinical hammer. When we tap the tendon with the hammer, it will show some response. For example, in upper limb, we can test the DTR for biceps, triceps and brachioradialis. When the tapping is done on the tendon of biceps, then biceps jerk is checked, and when on the triceps insertion, then tricep. In brachioradialis, we tap the tendon on the insertion of the brachioradialis muscle. In knee joint, it is tested below the patella and in the quadriceps tendon and ankle. This is tested applying clinical hammer over the tendo-Achilles tendon, gastrocnemius and soleus muscle. So biceps or any jerk is displayed either shows absent when the no reflexes is seen, no jerk is seen, then absent is given. When the tendon reflexes is diminished, then 1 plus indicated by 1 plus, and when the jerk is normal, then it is indicated by giving 2 plus, and when the reflexes the jerk is exaggerated, means more than the normal, then it is given 3 plus, and when the reflex is seen very high, then we give 4. We can display it by giving 4 plus, which is also known as brisk. Limb length. So limb length measurement, we can measure the limb length for knowing the limb length discrepancy. Some patient has shortening of the limb, then we measure the limb length. True shortening is measured from ASIS, that is anterior superior iliac spine, to medial malleolus. True shortening. And apparent shortening was measured by the help of measuring tape, and it is taken from apparent shortening taken from umbilical to medial malleolus. Next one is ambulatory status, whether the patient is bedridden, means bed bounded, or he can ambulate through the help of crutch, auxiliary crutch or elbow crutch, or with the help of cane or stick, or wheelchair bounded. We should mention that. Functional examination. In functional examination, we can assess about the activities such as dressing, combing, washing, eating and toileting. These activities are assessed and should be mentioned whether the patient is independent or slight assistance is needed to do the activity, or moderate assistance is necessary to do the movement, or the patient is fully dependent, means he cannot do that activity at all. Next one is the lower limb activities such as running, a stair up and down, means a stair climbing up and down, and cycling. These activities are also expressed like the upper limb. Next one is gait analysis. Gait analysis, we analyze the gait in swing phase and in stance phase. The width phase, the stride length, the step length, the cadence, these are analyzed, and if pathological gait is present, if any, it can be mentioned, such as circumdictory gait, hand to knee gait, scissoring gait, etc. Next is a special test. A special tests are those tests which are conducted by the physiotherapist or clinician to know the disease or injury. For example, for testing the knee injury or for testing the ligamentous injury of the knee, we can conduct McMurray test and Aptis test. In the same way, for for ankylosing and for the spondylitis, cervical spondylitis and lumbar spondylitis, they are investigated or they are tested through the foraminal compression test or the SLR test for low back pain. Next one is investigation. We can ask the patient for investigation if any necessary, and if he has the report of investigation we can see the report, and then we should mention the finding of the investigation. Next one is pathological findings. There are bloods and urine related pathological examination which also confirm about the certain disease such as the ESR, the RA factor, the ASO titer, the HLA-B27 test, etc. In radiological examination we can investigate by X-ray, CT scan, MRI, bone scan, myelogram, electrodiagnostic study, etc. And we can also know the findings or the report of the test should be mentioned. Next is diagnosis. On the basis of all these evaluating procedure, we come into diagnosis, and then the aim of physiotherapy. Mainly our aim is to relieve the pain, to increase the ROM, range of motion, to increase the movement, to increase the strength or power, and independent in ADL. And the last treatment.